Okay, so welcome and congratulations for Nurses Week. You guys all know me. So I was asked to speak about treatment modalities, which I took it to mean to explain the new stuff we're doing that we have never bothered to stop and explain before. So that's what we're going to do today. I'm going to assume you guys know the basics, although a few things are mentioned here just for those who might view the slides separately. When we talk about coming to detox, it's important to remember the context of the situation. So people usually wish they could just quit. They could just get over the hump, everything would be fine. And that's kind of why they're focused. But at the same time, we know that people who are detoxed successfully without some ongoing plan will have a almost 100% relapse rate. So we're trying at the same time to direct them to a plan that will give them an opportunity to stay sober. And that's going to affect not just the discharge planning and the counseling, but it's also going to affect the medication management. So as we start to think about our treatment options for opiate-dependent patients, we have to have a sense at the beginning where we're trying to get to, so we know how to get there. These are some of the destinations you can get to. So in the first box at the top are basically things that involve going home. A lot of people want to just quit. Some people are willing to see an individual counselor. Some people want to go to recovery meetings. And the majority of our patients are willing to go to intensive outpatient treatment, which you guys know is 3 hours a day, 3 days a week. Some patients will go to inpatient treatment. That offers a lot of advantages, obviously. I mean, we tend to think of the inpatient treatment as the patients think about it that you just can't use, so you get at least 30 days sober. But it's actually true that you'll have less symptoms of withdrawal in an inpatient setting than at home. Because symptoms are determined by triggers. When you're around things that remind you of using, in addition to the fact that you might use, your cravings and actually your physical withdrawal symptoms get worsened. I talked to a lady once who was 3 years sober from heroin. She wasn't on maintenance therapy. And she was walking down the street and her old dealer came walking by. And when she saw that person, now he did not recognize her. They didn't actually talk. But upon seeing her old dealer, she started to have physical withdrawal symptoms, a runny nose and watery eyes and shakes and all that stuff. So triggers are going to make it a lot harder for the patient. There's medication options for opiate withdrawal, which we're always thinking about because they're in fact very, very effective. Methadone maintenance, Suboxone maintenance use, and naltrexone, Depo, or Vivitrol. These are very effective options. I mentioned here briefly medication options for alcohol, and of course the problem with the medications for alcoholism is that they are not very effective. They have a very mild and not bad efficacy, so they can be adjunctive, but they're not something to really depend upon, which is different than the opiate doses. So for methadone, I put some of this pharmacology down there just to keep you clear, so we're not making mistakes. But methadone maintenance is an effective strategy for opiate addiction. And if we're starting methadone, we should always remember that methadone takes a long time to get started, to peak at 4 to 6 hours, and that it lasts a really long time with a half-life of basically 24 hours. And it tends to accumulate over 3 to 5 half-lives. And we should also remember that you can probably give 30 milligrams out of the box to a person without putting them in any real danger. But if we give more than that, we're potentially creating risk of restoration. Of course, if you're on methadone maintenance, you go to the methadone clinic and take it there every day, which is one of the reasons it works so well. There's a lot of accountability and a lot of structure. The big problem for us with methadone maintenance is that it's very hard to become a patient at a methadone clinic if you're not pregnant. So for the DSH or Medicaid-funded clinics, they have a certain number of slots. There's a waiting list to get in. The pregnant patients jump to the top of the list, and those lists move very, very slowly. Some patients have waiting lists for years, honestly. If you have private insurance, however, or if you can afford to pay for it, this is not so challenging. There are a couple clinics that specifically don't take Medicaid. There's one in Woodinville, one in Tacoma, one in Renton. And if people can afford the $400 a month, they can usually get methadone maintenance, which for some patients is an appropriate value. We don't usually deal with that too much in our unit for non-pregnant people because you don't really need to be at a detox system. Buprenorphine therapy is something you guys know a lot of. You've had experience with this. An agonist, antagonist, or partial agonist, which is why it works. It can, of course, cause precipitated withdrawal if taken too soon. We can talk about that in more detail later. There's a maximum effect that's equal to never more than 30 of methadone, so you really can't overdose yourself, which makes it so safe, which is why they let doctors prescribe it, which is the wonderful thing about buprenorphine therapy. Your doctor can write a prescription, a week's supply, a month's supply. You don't have to go every day, which is convenient. But that's also the danger, of course, because then you've got that medicine in your pocket. You can't really take extra Suboxone. If you do, it doesn't do anything. Some patients do, but there's no real effect. The temptation, of course, is to give it to your friend or your cousin or your sister. Yeah.
Could you talk a little bit about the potentiating effect with benzodiazepine?
Let me say that for a second, so that's going to get really tricky. But again, the biggest issue with Suboxone maintenance in terms of the success rate has been the possibility of diversion. Someone may give it to another person who they love who's also withdraw, and then that person goes through the cycle. It's certainly true that a number of people who use other drugs too will use them on Suboxone. Whether it potentiates the effect of the opiate is kind of hard to say. It still has significant dangers. There's been a lot of talk about the risk of overdosing benzodiazepines with Suboxone. I think that's honestly a little bit overblown. You can overdose with Suboxone, or rather, you can overdose if you put Suboxone and benzos together if you're not a normally opiate-dependent person. If you're a normally opiate-dependent person, Suboxone is going to have a very mild effect, no matter what. If you add benzos, there's some risk, but it's not nearly as risky as taking benzos with heroin or Oxycontin or methadone. It's a lot less risky than that. The only overdose deaths we really have with Suboxone, other than there's some cases of some children that overdosed and had to be rescued, but really the only overdose deaths have been reported with benzodiazepines, probably with alcohol as well, and probably patients who are not sort of everyday opiate users. So for people who are identified being dependent, it's not such a big deal. But if someone takes it who's never taken an opiate before, you can get intoxicated from it, and if you combine it with the benzo, you could be in danger. So the naltrexone is just an opiate blocker. It has no agonist effect whatsoever. It's a pure blocker. It's available as this once-a-month depot injection. And this is helpful for sobriety because if you can manage to get the injection started during that next 4 weeks, if you try to use opiates, they're not going to have any significant effect whatsoever. It's tricky to start it because it can cause precipitated withdrawal, and that's much more significant than you get from buprenorphine. And although the medicine doesn't help your withdrawal, in fact, in the short run, it can make your withdrawal worse because of its blocker properties, it's still very effective for cravings. And it's the same way that going to treatment helps with cravings. If you think that you could use, it's hard to stop thinking about it. Right? If you know you can't use, it's easy to put that thought aside. And I talked to one lady who told me she felt like there was a little devil on her shoulder and an angel on her shoulder all day long. Even the day she didn't use, she still kind of wrestled with that. And when she had a medicine like this that was off the table, she actually felt more happy. So it is effective for cravings in that sense. If people keep getting it every month, they'll stay sober from opiates during that time. Of course, there's no guarantee they'll stay sober from everything, but it usually works well. Starting, it's the problem. So in terms of starting, with methadone, you can start it right away. In fact, you can start it while people are still continuing to use illicit drugs, which is how they start with methadone. With buprenorphine, you have to wait a little while. We typically talk about 24 hours for short-acting opiates like heroin. We've certainly started it smaller. I'm going to put those words down below here. One thing we've seen in our experience is that if you start with lower doses, it appears that you can start sooner without the risk of precipitated withdrawal. So buprenorphine or Suboxone comes as an 8 milligram tablet, comes as a 2 milligram tablet. You can cut the 2 milligram tablet in half, that's not so bad. There is a film version of these, although they don't have them in the hospital. But we of course have liquid parenteral buprenorphine, which can be used sublingually in doses as low as 0.15. And we've found by experience, not much research on this, that you can start those lower doses much, much, much sooner. And we've had experience giving it as soon as 4 hours after a person's last opiate use, and doses like 0.15 and 0.3. We really haven't seen any major troubles. But if you ramp it up too fast, we have seen problems occur. For methadone users, you typically want to wait 48 to 72 hours before trying to get buprenorphine, and that's where the idea of the bridge came about. Basically, we take a short-acting opiate, in our case usually dilaudid or hydromorphone, and we give that for those 72 hours. And then we're back to a short-acting opiate situation, and it's easier to start in the usual fashion. So naltrexone causes more precipitate opiate withdrawal. Buprenorphine is an agonist and an antagonist. Naltrexone is just an antagonist, just a blocker. And the official recommendations are to start after 7 days after short-acting opiate. We often find patients very impatient to get out of the hospital, and insurers are not so keen for very long stays. So we're always tempted to try to start the naltrexone earlier. And we found from experience we can usually start it on the 4th day after short-acting opiates, and it usually goes pretty smoothly. About 1 out of 4 patients will have some significant symptoms. 3 out of 4 do pretty well. If we wait another day, a 5th day, it's going to be a lot easier. Conversely, if we go on the 3rd day, it appears that at least half, maybe more than half of our patients go pretty crummy when we start on the 3rd day.
So with the methadone, with the naltrexone, how long you would wait?
A long time. Probably,
how many days?
Well, no one knows, but probably
because we
more.
did this yesterday.
I'm well aware. Probably more than 7 days. But honestly, there's no clear data. Which brings us to 2 concepts. One is the idea of the test dose, And then we're going to talk about something a little more complicated than that. So if I want to give that injection, I give the injection, it's in the patient for a month. Methocarbamol or Robaxin is the other muscle relaxer we use a lot of. When you hear the word muscle relaxer, it's good to be careful. That's a category of medicine that doesn't really mean anything. A whole bunch of different drugs that are sleepy in some way are described as muscle relaxers. Benzodiazepines are called muscle relaxers. Soma, which is basically barbiturate, is called a muscle relaxer. But cyclobenzaprine or Flexeril is called a muscle relaxer. That's basically a tricyclic, really. The mechanism of methocarbamol has actually not been clarified, but my assumption is from the way patients act and from what we know about the chemistry, it's basically like a tricyclic, like giving some trazodone in the daytime, basically. The people at Highline who we borrowed a lot of this protocol from feel that when you give Robaxin with the tizanidine that it's too sedating and too ataxic. We haven't really seen that here, but we probably had about 6 or 7 patients who got the methocarbamol on top of the tizanidine. We've actually taken it off the standard protocol for that purpose. But I think if people are having a hard time, it's a reasonable thing to try. But we should keep a lookout for that because you don't want people falling over. And that's something that they've reported in some of their patients. Which brings us to the package. And this is what's affectionately known as the Blue Plate Special.
Where did you get that name?
We borrowed it from Dr. Greg Rudolph, who's actually a graduate of our fellowship, but he really put this together himself in the detox program over at Highline. And he said it worked fabulous, and I was honestly completely skeptical that it would work that well. But because we wanted to start the Vivitrol, we switched from using our old protocol, which was just 4 days of buprenorphine. And I have to say, I think it's worked phenomenally. We've had some patients at very, very high doses of opiates who seem like they're doing okay. They definitely feel a little bit worse. Typically, we'd start buprenorphine, people feel back to normal on day 2. Patients feel tired and a little bit grumpy when we're left alone. But they're tolerating it well. Our AMA rate hasn't gone up at all. And it gives us more options in terms of their care. Yeah.
So people might use Cataprexin.
Cataprexin is clonidine, and we still use clonidine, but again, we found that tizanidine, maybe because there's less side effects, or maybe because it's more effective, has been much, much better. Our order set actually allows the clonidine or Cataprexin to be given on top of the tizanidine, but it rarely has been necessary. I find patients not getting a lot of clonidine, but we always used to see that they couldn't get as much as they needed because of low blood pressure and low heart rate, and we just don't see that anymore. So I think we have a better solution, I would say. Although,
This is something that, most detoxes that are not hospital based, like county detoxes and stuff, use more than the special.
Clonidine's more common, it's a lot more studied. I could only find 2 research articles on tizanidine at all, and one was actually in a rat, although it worked really good in the rat. Yeah, I think there could be more research on this, but our clinical experience is that it's been way better than clonidine. It's been really impressive. And with the combination, people have done remarkably well. I've been really impressed with what they've done. And that gives us options further down the road. There's an order set which is just released, I think, on Friday. It's officially available today. It's called the Opiate Withdrawal Orders, Non-Pregnant Patients Only, Non-Buprenorphine Detox. I'm told if you type blue, it'll come.
If you type what?
Blue. It's a blue plate.
Where did Blue Plate Special come from?
It's the nickname.
You made it up?
No, Rudolph made it up. Because a blue plate is like a fixed thing. Like you get a meal and it has the same, all the different 4 parts of your meal. And you can't, it's not ordering a la carte. It's a package deal.
Yeah.
And so this is a package of medications. And that's how it got that affectionate nickname.
So if we want to order clonidine, we have to order it a la carte?
No, clonidine, if you look at the
That's
list,
possible.
the scheduled meds, it's a little fuzzy here. The Vistar, the hydroxyzine, the tizanidine, and the gabapentin is scheduled, and clonidine and Bentyl are still available, as you might say, a la carte. But it's on the orders. It's on the orders. Although I'm not sure why Imodium, I think it's up there because I believe Imodium is on our standard admission order set. Like it should be.
So is it staying the same for the clonidine? Because now we can give the clonidine every hour.
I asked them to change it to every 4 hours because I thought that was a wacky thing in the first place. I think every hour is too much.
For some patients really need it every hour.
Oh, yeah.
And some patients really need it.
I'm going to get a rebellion.
Yeah, you are.
Well, for now, if we use this order set, you'll have to ask if you want it more than an hour, and if you get enough phone calls, you may wear us down.
Okay.
Again, we're a little bit worried about hypotension and bradycardia, so we won't with this right now.
Well, we would be charged with watching their vitals.
What?
We'd
Yes, of course.
be
We
charged
check,
with watching their
we have to
vitals.
check it before
So,
we get a clonidine.
so the question for me with that is how confident are we, and I've not seen data on this, I haven't looked, how confident are we that the clonidine has reached its peak effect when taken orally within an hour? Because it would be really worrisome if the pills still float around in the stomach, and then you send 3 down the pipe and you may get into some trouble. And that
Well,
worries
maybe
me.
every 2 hours.
Well, for now, you'll have to call, and if you
Alright.
get enough calls, you might win. Okay. All right.
You can Rochambeau.
What's that?
You can Rochambeau.
Rochambeau. Okay, so other things that are done. Here's our regular buprenorphine detox that you guys know from so many years. And it works because it wears off really, really slowly. So it's going to be a smooth way out. And maybe it's true that the antagonist properties actually help move the patient to be less physically dependent. We've done this for almost 10 years for patients who are going to inpatient rehab, and I'm super satisfied with it. It's probably true that as it wears off, they have a little withdrawal, but they're in a non-triggered environment, and they usually tolerate it pretty uneventfully. I've heard about a handful of patients who felt fairly ill when they were at their treatment center. I haven't heard about people leaving AMA over withdrawal symptoms in the treatment center.
I have a lot of experience with that as being an inpatient counselor at Highland, where that was a protocol
Yeah,
for many
how was the
years.
sense?
And it was kind of like at the thirds. You know, 2/3 of people have some symptoms of like not being able to sleep is the biggest one, and 1/3 of people have no symptoms.
So I'm just going to say that louder for the video. So at Highland, the experience was 2/3 of people had some symptoms and 1/3 did really great.
Yeah, and then 1/3 had them really bad, but 2/3 it was not a big deal. But sleep was the biggest one for them.
Right, although we usually leave people on the trazodone for sleep, and that usually helps. We started doing this protocol because the traditional feeling was that when people went to rehab who were opiate dependent, like everybody would leave AMA by the second day because they couldn't tolerate the symptoms. And we found we could very successfully get people off to rehab. On the other hand, you're to some extent postponing symptoms, right? You're going to smooth them out and drag them out, and some are going to be later. For people who are going home, that seems like a real disservice. That they feel okay here and they have some stuff at home. That seems like the worst case scenario, like we haven't detoxed them at all. So I think this is still a reasonable regimen to consider for people who are absolutely, definitely, unequivocally going to inpatient treatment. But I would not allow it or consider for people who are not 100% on board. It does get a little tricky though, because people would rather have this because they feel better today. And if somebody hears across the hall, I want Suboxone, and you're telling me no, and the guy across the hall is getting it, that could be a little bit of trouble for us. So if we do offer this to any people, we want to be pretty sotto voce about it. We don't want it to get around that anybody can have this. We have had people who've had Suboxone with us before. We're very frustrated if we're not giving it now. But honestly, if it doesn't come up...
You mean in previous admissions?
Previous
Yes,
admissions.
yeah.
But honestly, if it doesn't come up, most of our patients treated with the combination of drugs in the blue plate special have been really very satisfied. Even people at very high doses have done remarkably well. We had a couple people recently that we gave a little tiny bit of buprenorphine too early on. They came here and they were just thrashing about the first day. It was very hard to settle them down. And we gave them a couple of like 0.6 milligram doses and no more, and they did wonderful. And so that's an option too. You can kind of split the difference a little bit. But if you do give buprenorphine, you're pretty much taking off the table the option of using naltrexone because you won't be able to wait long enough to give it. So that's the one. Methadone taper has been done for a long, long time. It goes back for ways, typically done over 3 or 5 or 7 or 10 days, and it really just doesn't work for the length of stay that we're set up to do. So that's not an option for us. Are there any? We're going to switch to alcohol in a second. Are there any questions about any of those things?
Before you switch, I would make one comment on the use of the term blue plate special, which is refrain from using it in your documentation.
Definitely. Definitely. And I've actually made for myself a dot phrase that lists tizanidine, gabapentin, and Vistaril. And so I have a short one with just all in one sentence. I can drop it in a sentence. And I have a long one that lists them out as a column. So it's called blue. But I can just put that button if I want to say, I can say patient was treated with dot blue and then the names come in. But it definitely would be not professional communication, casual communication. Any other questions? Taking longer this time.
Are we going to have DVD with this?
Yeah, it's going to look behind. It's getting taped right now.
Oh,
You're very
wow.
common.
Thank you.
So alcohol withdrawal is mostly the same. There's a few things that we're doing a little bit differently, but not a ton. You guys know the risks of alcohol withdrawal very, very clearly, including risks of death and delirium and seizures. And so we want to be extra careful with our alcohol withdrawal patients because they slip off. The basic treatment you guys are experts at, it's basically substitution therapy. Benzodiazepines take the place of alcohol, and then we wean them down. Alcohol works at the GABA receptor, and then people have downregulated GABA function. Benzodiazepines work at the GABA receptor. So we're basically giving them what they're already used to and just bringing it down gently, which is why how much you give and when you give it is so important. Fortunately for the physicians, the nurses do all the work in that regard by measuring their symptoms and attaching their medications to their symptoms, which works beautifully well. You guys know how to do it super well. There's a little bit of debate about which medicine to use. Again, this is old hat, but it's good to know that. Lorazepam kicks in pretty quickly, especially when you give it IV. Chlordiazepoxide or Librium kicks in a little slower, and it lasts a lot longer as an active metabolite with a very, very long half-life. Typically, we want to use, I'm going to go back here. Typically, we want to use the Librium. Typically, the Librium is better from an addiction perspective because drugs that kick in fast are very reinforcing, and people want more. So people like the idea of a drug that gives them a quick rush or a quick relief, you might say. Right? That's what they want. But on the other hand, the slowness of the Librium is going to decrease the reinforcing aspect, and that beautiful long tail helps people wean down. So we want to use Librium most of the time.
What about people with high ammonia?
We're going to get to ammonia levels in a little bit. That doesn't affect this decision. So when do we want to use lorazepam? Well, you want to use it when you need it right away. A patient who's about to get into 4-part restraints, who's delirious and combative. We don't want to fool around waiting 4 hours. You want to use it when you're going to give a lot. If you anticipate you're going to need a lot of medicine, you might give a little bit more than you need. Honestly, for bad DTs, I'd rather you overshoot than undershoot. On the other hand, if we give too much Ativan, the patient will sleep all night, wake up in the morning. If we give too much Librium, they'll wake up on Thursday. So we want to be careful. So if we're giving it hard, we'd rather use the lorazepam. If someone has a pretty slow metabolism, an older patient, we use 60 as a cutoff, or a bad liver, we'd like a slower drug that wears off more quickly. I don't really care if their AST is a little high. When I think of a bad liver, I'm thinking of a patient with jaundice or ascites, elevated PT, low platelets, that kind of a really cirrhotic patient. And we'd like to use lorazepam if there's a risk of overdose, because the Librium really accumulates. So if a patient's getting concurrent benzodiazepine, if they're a sleep apnea patient, we're really worried about respiratory suppression, you might prefer lorazepam in that patient. There are some times that you give a ton of benzodiazepine and it doesn't seem to work at all. Okay? That's because benzodiazepines require the presence of the GABA neurotransmitter to work. It's kind of like GABA binds the receptor, it opens the receptor, and benzodiazepine sticks a stick in there so it can't close again. It keeps it open. If there's no GABA, though, there's no effect. Some drugs will work even in the absence of GABA, specifically barbiturates, which for us is mostly phenobarb. So we've used phenobarb sometimes, and phenobarb can be more effective than benzodiazepines or work in a patient who seems to be benzodiazepine resistant. But there's a price you pay, an increased risk of respiratory suppression. So we want to be very thoughtful about this. It comes in a vial of 130, so for some crazy reason the numbers are 65, 130 to 60. I tend to be really cautious with each dose. 65 is a pretty low dose, half or a milligram of Ativan. 130 is kind of a normalish sort of dose, and 260 is sort of reasonable, maybe equal to 2 to 4 milligrams of Ativan. But this stuff's going to stay around a really, really long time, and it's going to tend to accumulate. So I like to give a dose, see what we got, give a dose, see what we got. If you have scheduled phenobarb, and you're starting to get a little worried about respiratory suppression, don't give it. Call the provider and check in, because this will put us in some risk of getting patients intubated, which we don't like to do right. In the ICU, they can be more aggressive with this, but for us, we're careful. Propofol is another drug that works at the GABA receptor. They use this for general anesthesia. It's very profoundly effective. What's that?
It's the Michael Jackson drug.
Yes, exactly. And it will make you stop breathing in the same way as Michael Jackson does. So this is used in the ICU only here at Swedish. And then baclofen is kind of an odd duck here. It's not a very strong medicine unlike these others. Baclofen is also a muscle relaxer, but it's a GABA drug that works at a subset of the GABA receptors called the GABA2 receptors. There's been some small open label trials suggesting it might be effective for alcohol withdrawal. Whether it is or is not entirely clear. I gave it to one guy once who wasn't responding very well to our benzos. I wasn't impressed with the effect, but we may try it once in a while. So these are things you may see. The seizure medicines we use a lot. You guys are very familiar, but it's worth talking about the logic behind it or the evidence behind it, because the evidence is not that overwhelming. Seizure medicines have been studied in low-risk alcohol withdrawal patients and proven to reduce the symptoms of alcohol withdrawal for patients who weren't really that bad in the first place. Less anxious, sleeping better, less CEWA scores, less benzo-per-CEWA scores. Interestingly, less short-term relapse in the first few weeks after they left the hospital. It's not exciting. One study actually looked at Depakote versus Ativan, so they didn't get any Ativan, and the patients who got Depakote were actually less anxious and slept better than the Ativan patients, which I found pretty exciting. There's probably something about the patients who aren't getting anything, just like the patients who can't have any cigarettes, kind of forget about it after a while, whereas when you're getting some medicine in that category, sort of your dependence is still cooking along. But their efficacy is not entirely clear because they've only studied these low-risk patients. They've not been proven to prevent seizures due to alcohol withdrawal, despite being seizure drugs, because the research trials did not look at patients who had seizures before. So basically, they haven't studied patients likely to have a seizure. We believe that they prevent seizures based on our experience, but it's not proof by long shot. We have found that when we have a therapeutic level of these medicines, we basically never get a seizure. I've had 2 exceptions. One was a person with a very profound seizure disorder. He told me every time he knocked his head, he'd have a seizure, even when he wasn't drinking. The other guy actually turned out to be faking. He admitted, they weren't even pseudo-seizures. He later on admitted he was faking the medications. We have had a handful of patients going through benzo withdrawal who had a seizure when they didn't have a therapeutic level, when their level was too low. So that leaves me relatively convinced that these work, but they're not proven. We know that these drugs don't do anything to help delirium, because we've had a lot of patients get delirious on seizure meds. And theoretically, could make delirium worse, because the patient's symptoms are better, so the amount of, their CIWA scores are lower, the amount of benzo they get per CIWA score is lower. We always assume that treating with benzos prevents the delirium, although that's not actually proven. But if that's true, then they could be more likely to get delirium in seizure drugs. There's no real trials that show that one way or the other, and our sense is that it's probably about the same. If it makes a difference, it's not much of a difference, honestly. These are the drugs that we use a lot. Depakote and Tegretol have been shown to be effective in our experience and shown to be effective in trials. There's some small trials with some other seizure medicines. They're not very well designed trials, 10 patients, no placebo, really hard to show anything. I actually just read a trial for gabapentin where they had 2 out of 37 patients actually seized despite gabapentin. But there's a general sense with gabapentin that it's the least strong of the various seizure medicines. It's just not as powerful as some others. So that's not super surprising. This is Depakote. Now, both of these drugs are going to have significant risks and side effects, which makes using them not so easy. This is Depakote. We know so well. It can be given IV or PO, which is lovely. 20 mg per kg, usually divided twice a day. Depakote is valproic acid. It's actually divalproate. It's 2 valproic molecules bound together. Has a slightly slow release because of that. We sometimes use Depakine, which is pure valproic acid, for people with poor absorption, like gastric bypass patients. I've never seen any evidence about that. Dr. Hodel had suggested that. We do get better levels when we do. So it's probably true. Therapeutic level is 50 to 100. Probably 60 is plenty. We probably don't need higher levels. And we've definitely seen some side effects. So most alcohol-using patients come in with elevated LFTs. A lot of them come in with low platelets. So that's a little bit anxious for us. A lot of people have mild ammonia levels elevated before we start the medicine. Depakote reliably will increase ammonia levels in most patients. And we typically see levels in the 40 to 70 range when we check. Whether that's clinically significant is not clear. Almost all those patients appear to be ineffective. We have had a handful of patients in the 100 range, maybe one a month or so. Most of those patients look pretty normal. They're awake and you can talk to them, maybe a little fuzzy-headed. We've had 2 patients where you couldn't wake up at all. They were breathing, but they were completely unrousable due to this ammonia. So when the ammonia came down, they woke up. That's a small percentage of the people who've had those high levels. We don't really know how worried to be about that. There is some evidence that a substance called carnitine or levocarnitine, which is actually a nutritional product sold over the counter, may help prevent this. And we're thinking about giving that a shot. We're kind of wrestling with whether just doing it or whether to do it as a research trial, which we don't really know how to do yet, but we may get into some research. So this is probably the easiest study someone could do. So I've been negotiating with the pharmacist, and you may see that happening at some point. Tegretol is dosed 200 TID. Note it's not adjusted per weight because we don't know how to adjust it per weight, and that's probably one of the big problems with this medicine. Some patients get pretty high levels and they're more symptomatic. It's a good idea if they're smaller not to give them as much, or if they're elderly or if they have a bad liver not to give them as much, or conversely check the levels really early so they don't show too high. It's known to cause low sodium and reduced WBCs, again, which are common things for alcoholics. We see this vertiginous ataxia in some of our patients, usually littler patients because their levels are too high, and it seems to be related to therapeutic level. You can get less of this ataxia by starting slowly, but for detox purposes, we can't start slowly. We have to start it quickly to avoid withdrawal symptoms. So this has been an issue for us, and we have actually a patient who's very vertiginous today with a Tegretol level 14. The therapeutic range is 6 to 10. Honestly, 7 is probably fine. We probably don't need those high levels. So I think if we keep those levels down, we'll get less of that stuff. But it's one of the reasons we switched to Depakote as our sort of first-line drug. There are, for both these medicines, a lot of drug interactions, and so it's worth checking that out. If you have worries, you can ask the pharmacist, or if you're Hippocrates users, you can easily look it up on Hippocrates. Okay. Antipsychotics are important, but also dangerous. Antipsychotics seem to be very helpful for the treatment of delirium, alcohol withdrawal symptoms. People feel calmer, they sleep better, they get less bizarre and vivid dreams, and it clearly stops the hallucinations. That's excellent. People usually like the effect of the medicine, although some people don't like the kind of fuzzy feeling. The risk has to do primarily with arrhythmia, irregular heartbeat. These drugs all cause prolonged QT intervals, which can lead to torsade de points, which is basically the same as dying, unless you cardio for the next day. so potentially dangerous. On the other hand, really powerful for symptom relief and really help people. For our benzo withdrawal patients, this seemed really essential. I've been here working with the unit for about 10 years. During that time, we've had a single death on the unit. There was no cause of death found by autopsy. It was a 47-year-old. We're assuming that was an arrhythmic event. That patient had some cerebral and some heart. So we want to be extra careful and reduce that risk. We have a plan in place to mitigate that risk by monitoring the QT intervals, being thoughtful about when we give it, and trying to correct all the electrolytes. We've always corrected potassium, but now we correct ionized calciums and phosphoruses and magnesiums, and hope that will lower the risk.
You do, how often do you do the EKGs on Seroquel?
So what we've been doing is for young, healthy patients, we've assumed that a low dose is probably fine. And if we start giving more than 50, we'll check a QT after they've received the 50 to see if it's okay. For patients who are elderly, who are frailer, we're more likely to have nutritional problems or electrolyte problems, we're getting an EKG before we start it, and be more careful. Interestingly, these meds are usually used for mental health purposes. Nobody even thinks to check this stuff. But it has been shown that people on these medicines do have a higher risk of sudden cardiac death. I had always assumed that was just due to getting fat, because they know they can make you gain weight, but probably it's due to this QT problem. So, and of course, alcohol withdrawal is a stressful condition, and it's worth being more careful. So
I know
we
you get your EKG before you start the Seroquel, but do you monitor it afterwards?
Absolutely. So
Every
well,
day,
it depends what we get. So a QT of 500 is bad. That's a place you don't want to be. A QT for, I think it's for men under 440, for women under 460, is considered normal. So that's pretty good. So if I get a really good QT, if I get a 420, I might not check again unless I'm given a ton of Seroquel. Okay. But if I get a borderline one, which we see a lot of, right? So below 460 is great, over 500 is terrible.
Right.
Between 460 and 500, you're in the gray zone.
Right.
If I get to 490, I'm pretty worried. If I'm 470, I'm not that worried. The more in between it is, the more we're going to check it. So interestingly, QTs are always a little bit better in the morning. We tend to check them in the morning. Is that okay? I guess that's okay. If we check them in the evening, they might be a little bit higher. Stress and heart rates can all intervene with these things, and electrolyte abnormalities and a lot of medicines can intervene with these things too. QT intervals are worse with a variety of medicines, some of which seem quite benign, like erythromycin can affect a QT interval. Honestly, methadone can affect a QT interval, probably at very, very high doses. But honestly, for us, the big one is the antipsychotic. So that's the one we're focusing on. And again, if it's an older patient, we're probably going to check it before we start, and for a healthier patient, before we get too far along. We'll see how they do in the morning and decide where to go from there. You can use Haldol. We used to use a lot of Haldol. We don't use it as much anymore. It doesn't last as long, and that's one nice thing about the Seroquel. Side effects seem better with the Seroquel. If you use Haldol, the thing to remember is that parenteral doses are much, much stronger than oral doses. So 1 or 2 milligrams is a small dose of Haldol orally. 5 milligrams is a pretty big dose of Haldol orally. But an IM dose of 1 to 2 is pretty powerful. An IV dose of a half a milligram to 1 is pretty powerful. So it will happen sometimes that we're having combative patients physically, and we've given them a lot of Ativan, we're pushing as hard as we can, and we're attempting to give a little Haldol, and that's okay, that's very reasonable to do. But we don't want to give a 2 to 5 milligram IV dose, that would be a catastrophe. So if we go with parenteral Haldol, you want to go very gently, and if you need to give more, give.
Do you Haldol to elderly patients?
I might, but again, I'll be much more careful watching things. So it's not unreasonable to we've given Seroquel to elderly patients. They're roughly similar drugs, honestly, but you just want to be more thoughtful about side effects. Again, most importantly is QT stuff. Now, Thorazine or chlorpromazine we've used a couple of times, and I've actually been very impressed the 2 or 3 times we've used it. Typically, it was a patient who, for one reason or another, was refusing all the antipsychotics they'd ever heard of. So we had to come up with something that they hadn't heard of. But it's been very, very sedating, which in our setting is actually a good thing. I've only seen it used 3 times, and each time the outcome was really wonderful. From a QT perspective, probably the same kinds of things. Side effects like sedation, kind of fuzzy mouth, probably a little worse. That's not such a bad thing in our setting. So we can think of that as an option from time to time. And someone in the last session pointed out very good for hiccups too. There's a bunch of other medicines that probably help alcohol withdrawal in the same way that they help opiate withdrawal. They're sort of vaguely drowsy. Central acting alpha-2s, like clonidine, help with restlessness and shaking and sweating. Beta blockers also help those symptoms, also help tremor quite a bit. None of these drugs will prevent seizures, and they can sort of allow a seizure to pop out because now you're missing your CWIS score. But if you have a seizure med, you might feel very comfortable giving these kind of medicines. Conversely, if you have a patient on some of these meds, maybe for cardiovascular conditions, you might miss some of the alcohol withdrawal, and you might be more prone to use a seizure medicine because you might not have full protection. Baclofen may or may not work. Again, I used it once. I wasn't overwhelmed, but there are some studies showing it to be helpful for low-dose patients. And antihistamines, which we already do now, we allow a low-dose visceral for anxiety, might be somewhat helpful. It'd be interesting and tempting to give a seizure medicine and all these meds and see how well people do, but honestly, the evidence is not as clear. And we know that the meds on placebo score is still the safest way. So we add these other things in for patient comfort to help length of stay, but it's our responsibility then to make sure it's very safe. So keeping patients adequately hydrated, correcting electrolyte abnormalities, and keeping an eye on QT intervals is really important. So I wanted to put this in because we've kind of changed a little bit, not entirely consistently, our approach to thiamine. So traditionally in America, if you came in for alcohol withdrawal, you got thiamine 100 milligrams a day, orally or IV. People don't really think a lot about it. Thiamine deficiency has to do with this disease, Wernicke's encephalopathy, which is really a special part of your brain dies. And it dies because the metabolism of carbohydrates, specifically glucose, requires thiamine, and I don't know, some bad thing happens if you don't have it. Typically happens when people get IV fluids with glucose in them, which is why I don't even want to have IV fluids with glucose on our unit at all. And we should never be giving IV fluids with glucose to any of our alcohol patients. There is a role for them with the pregnant moms. You can use it for an OP person if you want, but we should never be giving IV fluids with glucose to any of our alcohol patients. People talk about feeding first, and that maybe is an issue, but it's traditionally been IV fluids, which are really the primary risk due to thiamine deficiency. The symptoms of Wernicke's encephalopathy are confusion, ataxia, and tremor. That sounds pretty familiar to like all of our patients, doesn't it? There's also nystagmus, which is weird eye movements, and ophthalmoplegia, which is basically a one sort of lazy eye, one that eye doesn't move right. I used to believe we didn't have to worry about this because I've never had a patient on our unit with nystagmus, so we can't be having any Wernicke's encephalopathy. But then I read that a lot of patients don't have those eye symptoms. Probably only 20% of people have all that stuff. And it turns out that autopsy diagnosis of Wernicke's encephalopathy shows that most of the cases are missed. There's 20 times more cases found on autopsy than are ever diagnosed. So if we're having it, we're missing. And we're probably having some else. It kills a little piece of your brain, which can cause a kind of dementia, an anterograde amnesia, where you can't remember things going forward, kind of like that movie Memento.
That's how it's characterized.
Pretty devastating.
If you could tell me if Wernicke's is on a continuum, or if you get it, is it this severe, or...
They usually talk about it having it or not having it, but you know, there's no question that you can have it to degrees, because you're basically killing a piece of your brain. I didn't list the places, but there's like 5 or 6 places that classically have it. They're all kind of deep in their brain, probably having something to do with blood flow. And near the thalamus and the central areas. And clearly the bigger a whack you get, the more trouble you're going to have. So there's no question you have 2 degrees. Interestingly, you can actually see this on MRI, not 100% reliable, but you can, I mean, it's a real thing that you can look at in the brain. And people have some permanent brain damage. And the famous alcoholic wet brain guy we used to talk about, this is probably what happened to that person. So this is pretty serious. So we'd like to prevent it. Now, to have our normal diet, you only need 1.5 milligrams of thiamine every day, but it stays in you for a long time, so you have to build it up. When you drink, you absorb thiamine worse, significantly worse. But honestly, you eat a lot more than you need. And studies have shown that as long as the person's eating, they're probably getting enough thiamine. That's why I'm asking you, are they eating? Does this person eat food every day? People who are eating food, especially red meats, honestly, are probably getting plenty of thiamine. But we know a lot of our alcoholics, especially the pint-a-day people or fifth-a-day people, they're not eating anything. They're just drinking. So their thiamine levels are going to be very low, as well as having poor absorption. Now, no matter how much you take orally, you only get a small amount in. So we give 100 milligrams PO. It's not the same as 100 milligrams IV. It's much, much, much less than 100 milligrams IV. So in the US, they usually give 100 milligrams PO IV. If someone has Wernicke's encephalopathy, they give 500 milligrams IV 3 times a day.
Oh,
Exactly. There have been some case reports, and this actually, I read this secondarily from recommendations in England, that they've some reports of this popping out despite as much as 250 milligrams of thiamine a day, preventively. IV. So they're giving a lot more than we are and kind of paying attention probably a lot more carefully than we are. Now our thiamine comes in vials of 100. So when I asked Swedish, can we go up to 200, 250? They said, let's just do 200 because it comes in a vial. I said, okay. So here's our recommendation. For people who are eating, it probably doesn't matter. So 100 milligrams PO, 100 milligrams IV, I'm okay either way. For our patients who are not eating food, who are malnourished, or who are throwing up like crazy, which is probably about 1/3 of our alcoholics, we want to go to a full dose of 200 milligrams IV daily.
I wonder if they're vegan, because a lot of vegans...
Vegan create a risk, and another thing that's a big risk is our gastric bypass patients are very high risk, and they should be considered high risk.
How about our patients who are not alcohol, but opiates or benzos, who are malnourished?
That's conceivable, actually. It hasn't been studied as much, but there's definitely conceivable. And I saw that there definitely have been case reports of people with severe, but it has to be like really severe nutritional problems. So the average heroin user who's kind of lost a lot of weight probably won't be so bad, but people are like cachectic, could be so. It's a reasonable thought. For patients who are in DTs, this is the biggest change. For patients who are actively in DTs, I would like you to assume that they're having Wernicke's encephalopathy because we can't really prove otherwise. Which means if they're in the real DTs and their patient doesn't eat food, we're going to go ahead and give them 500 pounds. And we have an order set called the ARS DT bundle, which basically is like an extra set of labs and incentive spirometry, PT, OT, and swallow. I added this to that. So when people pull up that order set, they'll think about doing this. And I definitely want to have you guys encourage our providers to do this because not everybody has this sunk in so deep with. What's really clear to me is this is not the standard U.S. practice. The standard U.S. practice is 100 milligrams is fine. But it's really clear to me that we're missing most of the cases of Wernicke's. So it's a really bad thing and a completely preventable thing. So there's really no reason not to be aggressive with the time. And I talked to the pharmacists, they're stocking up more of it. So again, for non-eaters, 200 IV daily. For people in DTs, we're going to go to 500 TID.
So it's pretty much everybody getting IVs or coming for alcohol withdrawals?
Okay, if someone's eating well every day, I'm fine with 100 milligrams daily because again, the best evidence I could find suggests that people who are still eating food, especially if they're eating meat every day, or even if they're drinking, they're probably getting enough. So it's probably okay. So it's really the non-eaters that we catch. And that's what I got. Any questions?
Well, thank you.
Fantastic. Nice job.
Do you have a handout on this?
Oh, I'm so ashamed. I was supposed to get a handout. Somebody told me to, but I don't have a handout. But I'll say one good thing. This presentation is going to be available online. And you'll find it, a notice on the Touchpoint website with a link. Exactly. What a great segue. So you guys are going to for certain stations here. You're going to learn how to use the breathalyzer. You're going to learn how to search your bag. But amongst other things, you're going to see the Touchpoint website. Touchpoints is the Swedish version of like a team site. A team site's what I should
It's
say.
a team site.
Team site.
It's set up on every computer, right when you go on ARS. I can show you.
And it's ways for us to share information with each other. There'll be announcements. The treatment calendar is going to be on there, and you'll see more and more of our stuff is going to be on the team site webpage. So you'll get an announcement through that. We're going to email everything out for a while, but it's going to be expected more and more that you'll use the team site, and some of the emails will just say, okay, check the team site. There's no email for you. All of our presentations will be available there, and you'll find links to it, including actually both the slides and I think the video too.
There's a lot of presentations on the team site.
Any other questions?
Well, this was great, thanks. As a non-medical person, I really liked it.
So there were some previous lectures given in 08, which is sort of a more introductory. This is sort of more meant to be more of the next
I
slide.
have a question about bowel care with our patients.
Bowel care is really important.
Yes.
Yeah.
Because we do have a lot of patients who have problems with that.
Yes.
And we don't like to bother our doctors much with that. Isn't there a way that you can set more into protocol that if this patient hasn't had a bowel movement, 3 days, you can give this more and more?
You know, we used to have, a long time ago, there was a very extensive set of bowel care orders, and I would say a long time ago we used to write the orders with the intention that the nurse wouldn't have to call the doctor.
Yes.
And there was a lot of things written out that way, all to avoid a call from the nurse to the doctor. And we came to the conclusion that was bad practice, that we'd rather have more communication than less communication.
About bowel care?
My first
I'm
favorite time. Actually, I'd say yes to an extent. Okay. To some extent, you have a guy who's in the hospital 3 days, he's going home tomorrow, and he hasn't pooped because he can't stand it, his roommate hearing him, and he just wants an enema. And I don't really care about that. But think about all of our opiate maintenance patients, all those pregnant moms. When I hear that they're constipated, I'm getting very important clue about the status of their opiate maintenance therapy. Because a lot of times they ask you for a constipation medicine, they're telling me they're having diarrhea, because they know that can be associated with a higher dose. So in that case, it's good. Some of the medicines that we use commonly can have electrolyte issues, like mag citrate and stuff like that. So although it's very tempting, because I hate to make you guys make phone calls, it's probably healthy for us to just stay in communication with that. So, there you go.
I have a question about the ammonia levels and what kind of method I am using to somebody who's getting high ammonia.
I'm not going to worry about the bends on the ammonia level. The ammonia level can be sedating, but that's not really a big issue for me. I just want to know that they're functional. I think we worry, and honestly, my opinion is, we had this one patient, that's 8 years ago, back when we had an ICU here. who we couldn't wake up, and it was really jarring. It was an interesting story. She had been started on Depakote. She was a benzodiazepine kind of patient. We put her on Depakote. Her level got up very high. Went up to 102. She couldn't wake her up. She went to the ICU. They gave her actually lactulose by rectal tube.
Yeah,
That's kind of icky.
At Highland, they give patients lactulose a lot of that.
And her ammonia level came down. Now, the terrible part was she was discharged from the ICU. It's an interesting story. Without the Depakote, which made sense. Another seizure medicine wasn't started. And about 3 or 4 days after she left the hospital, she had a seizure.
Yeah.
She then got admitted to another hospital where they put her back on the benzodiazepine. So not so bad about that. So around the benzo, though, I'm not super worried about that because the sedation that scares me is honestly respiratory suppression. And the ammonia, while it's sedating, is not a respiratory suppressant. So they're just drowsy. So I'm not going to sweat it. The part that I struggle with is after that lady, we started checking ammonia levels routinely. And again, we've had a bunch of patients with ammonia levels of 100, and it doesn't usually seem clinically significant. So I'm thinking about, with the team, just stopping checking it if they're not having symptoms. And you only check it if they're symptomatically. Because I feel like it creates a lot of worry and concern that usually isn't clinically significant. On the other hand, I'm always a little nervous. We send them home with Depakote. If they get more sedated at home, that's a little anxious. So if this other medicine, the carnitine, works, that could be, it's pretty cheap. It could save us a lot of trouble. And I'm excited to support it. But there hasn't been a lot of research done on it. But I wouldn't worry about the specific benzo. Okay? I'd say that the Librium is so much better in terms of people asking for extra medicine that they don't really need, that we really want to hold to the Librium when we can, as long as we're not compromising safety. Any other questions? Okay.